안녕하십니까.
Hello, Digital Dentistry's third lecture. Intraoral scanner strategy is going to be presented with this Dental TV. I'm Dr. Chun Se-young of Doha Good Morning Dental Office. When it comes to digital dentistry, I'm going to talk about how to accurately do the oral scanning and how we can utilize the precise scan data in our clinical setting. First, let me introduce the scanners. There are many different types. First, intraoral scanner and model scanner to scan the model, and the face scanner, which scans the three-dimensional face. As you can see, the most important things when it comes to scanner is the accuracy, scan time, and the head size. These need to be considered when you choose a scanner. First, iOS intraoral scanner. There are two types, capture and video types. Used to use capture type. That's the conventional type, but video type is more precise. So such intraoral scanner is being developed a lot and applied clinically. So video type is more precise scanner. For the full mouth or big area can be scanned, and the model is prepared for the scanning. The difference between iOS and model scanner, the precision is similar when it comes to small area, but for full arch or large area scanning, model scanner is more precise. iOS is more precise when you use video type, but the model scanner is capture type, and it is helpful in terms of time, but there's one disadvantage. The rubber impression should be prepared, and the stone model should be prepared for a patient. That is the limitation with the model scanner. Next is the face scanner. The 3D CT, the oral situation, can be captured with intraoral scanner or model scanner. Using a face scanner, you can utilize three-dimensional face information for denture patients, for anterior aesthetic prosthesis patient, or orthopedic surgery. It has the advantage of providing digital simulation. So a lot of research is going on for face scanner, and soon I believe it will play a bigger role in our clinical setting. First, the digital model is the Prosthodontics. Let me show you my patient, 90-year-old male patient. The patient came here to have a bridge at the anterior maxilla. As you can see, I did the preparation. After gingival cord packing, preparation for scanning was done. So this is the picture showing that situation. Actually, the intraoral scanner is working to scan the patient's oral condition. I use this Trios 3 equipment, which was purchased about 5 years ago. The basic approach is Modeless fabrication. It is used for prosthodontic, orthodontic, and guided surgery. We don't use the rubber impression material. With the scan data, fabrication is done with CAD-CAM. Currently, gingival cord is fabricated. This is a full arch mandible that is scanned. Abutment margin and the entire shape will be scanned more precisely using high-resolution mode. The margin is exposed clearly with gingival cord. The contact point, abutment, are prepared for precise scan data. The precise data with clear margin is required to fabricate prosthesis without a model. to produce the satisfactory fitting for the patient, contact points with the adjacent teeth, and occlusion with opposing teeth to reproduce them properly. Therefore, in acquiring scan data, we try to get very precise data patiently, like this. For crown scanning, I believe the most important clinical point is for good acquisition of scan data, deep subgingival margin formation should be avoided as much as possible to expose margin with cord for margin scanning. And after cord packing, for rubber impression taking, in most cases, the second cord is removed from the double cords. In the empty space, rubber impression material is pushed in and the impression is taken. I scanned like that for years in the past, but as you saw in the previous video, I don't remove the second cord of the double cord, and I pack it a bit more to scan the margin area, sulcus area, by blocking blood from coming out these days. So scanning has become a little bit easier. This is the way I acquire the scan data. I believe this is for your reference when you try to acquire oral scanning. Now, this is bite scanning. This is the same as bite registration using a model. Now we are using a scanner to do so. This is a full arch case. In the case of Trios 3, bilateral bite registration has been made and a process of adjusting the occlusion is taken. Patient's digital model is made in the virtual world. Another important advantage of digital is that patients can look at the contact points directly themselves. Before scanning, have an ortho patient bite on an articulation paper. Articulation marks would be obtained and compare them to the ones in the digital model. If they are similar or consistent, the accuracy of a bite vertical dimension or occlusion can be verified one more time. Now, digital model acquired from an oral scanner, it is moved to the 3Shape Dental Manager software for prosthesis. As you can see, the margin, crown, gingiva teeth have a very wonderful natural colors. The positions, volume are very precise, so we can fabricate the prosthesis Modeless by designing them here. It can be delivered to the patient with a satisfying outcome. This is the prosthesis CAD designing process. The first one shows the borders to make the model's die space. The middle one is the amplified picture. Accurate margin lines can be found to make clear the margin fit of prosthesis. The third picture is providing the cement space, just like die space is applied on the analog. Cement space should be accurately measured to make a prosthesis fit well. You need to find and set the values appropriate for a specific milling machine or 3D printer that you have, so that in the Modeless work, the Modeless prosthesis can be fabricated so that it can be accurately and in a fast manner delivered to the patient. This is the process of designing for pontic or crown. Just like this, the adjacent tooth contact point, contact of gingiva below a pontic are not estimated by a person but reproduced very accurately using measurements. Thanks to time saving and precision, we can do our clinical work easily and comfortably. And the digital designing make our clinical work very precise and convenient. It's very helpful in solving many problems. Using the Modeless approach in our office, designing is done, milling, sintering processes have been conducted, and the prosthesis is delivered to the patient. I cannot say it's a superb prosthesis, but based on my experience, clinically, it doesn't have discomfort, and actually it was pretty satisfactory for me and for my patient. Prosthesis was fabricated very easily for the clinical treatment. Now, let's look at oral scanning strategy for Quadrant. This is the video from the 3Shape webpage for teaching purposes that uploaded this type of videos. In the case of a Quadrant, whatever scanner you may use, it's pretty accurate and good scan data can be acquired to fabricate the prosthesis, but there are some things you need to consider. Scanning starts from the posterior occlusal surface, then lingual and to buccal at the posterior to acquire data. Now, to scan posterior occlusal surface, run the scanner in parallel to the surface to get precise data. When it reaches a canine or lateral tooth area, move to the lingual for the lower jaw. When bending, move a little slowly rather than in a straight line to accumulate the images in a precise way. For the lingual scanning, run the scanner in parallel, closer to inside of the teeth. When you reach the most posterior region, move to the buccal side. Move slowly, more slower, in cornering, then you move in a straight line. On the buccal side, as you can see, scan thoroughly the margin between gingiva and teeth. Then you will get data properly without major problems. Similarly, on the maxilla, from posterior to the anterior, scan the occlusal surface and then move to the buccal side to scan there to the posterior region. And then rotate it to the palate before moving to the anterior region. And this way you will get very good data in the quadrant scanning with this strategy. Now let me move on to the full mouth scanning. In the full mouth scanning, an oral scanner is used and there are some limitations. As I said before, in the case of a full mouth scanning, I said model scanner is more precise because an oral scanner is going like adding captured pictures continuously. So there are a lot of distortions in the data in the case of a full mouth. One body type prosthesis for the full mouth may have lower precision in terms of the fitting. So for the full mouth scanning, this strategy should be adhered to. As you can see, in the posterior region, scan in one direction, and in the anterior region alternate between lingual and buccal sides like this to add or attach the data from the opposite premolar area scan in a straight line. After the camera is moved to the lingual side, following the standard approach scan with the notion that the pictures are attached one by one connected with images of the occlusal surface up to the other side to have the data or the three-dimensional data free of distortions. When you move from lingual to buccal, scan slowly from lingual to the occlusal surface to the buccal side to provide as much data as possible to the machine to reduce distortions. And you can do the same thing to the buccal side. The tip for a full mouth scanning is that at the anterior region, you need to scan the lingual side and the buccal side alternating to continuously acquire a lot of data before moving on to the other jaw. This is the most important tip or know-how for scanning the mandible. Trios 3, Trios 4, when you use the device, the advantage with that is the tip can rotate 180 degrees. So you can rotate the tip to scan maxilla like this, which is very convenient. For maxilla, the same strategy can be used. Scan first the posterior occlusal surface, then from canine to canine attach pictures bit by bit, alternating between labial and palatal. The wide area is composed of many small images to get a lot of data. Unlike mandible, you need to attach palatal images as well. Next, secondly, bite is very important. Trios captures the bite in two areas. Scan from posterior to canine. Try to avoid scanning movable mucosa. Scan the margin between gingiva and teeth. The scalloped area. The morphological changes can be identified. The existing upper and lower jaw data can be merged to acquire very precise data. On the other side, the scanned data is acquired like this. More precise scan data is acquired. Next, crown. Let me talk about the crown scan for prosthesis. There are two scanning methods. The prepped tooth is scanned first, including the margin. Very precise scanning is done for the crown only in the beginning, and the rest of the things, including the adjacent teeth, can be scanned later. When adjacent teeth is scanned, the margin can be raised or changed. Therefore, this portion is locked. After that, the mesial tooth or adjacent teeth or gingiva can be scanned later. The second option, gingiva cord packing, is done. The whole quadrant scanning is done first. Precise margin or contact area with the adjacent teeth or missing is trimmed or deleted, and it is scanned again after moisture control or gingiva cord packing. So precise scanning is done for that portion again. So this is the crown scanning approach. So you can choose the first approach or the second option, whatever you can conveniently use in your clinic situation. This is a pre-margin scan for natural tooth. This is me filmed doing the scanning on a patient years ago. The most challenging part was the distal part of number 7. The gingiva cord was quite thick. You can see it is inserted. So that part the margin is significantly inferior to gingiva, so it is very hard to scan that port. Before scanning that portion, articulation paper is used to get articulation marks, and that is measured first. And the lingual and distal margins are not scanned properly, therefore the scanning should be repeated to get the clear margin in that part. So this required a lot of efforts. Therefore, thanks to the scanning, when I do the prep on a patient, I try to get very clear margin line, not too deep in the gingiva. As much as possible, I would like to get one line for the margin. So I got accustomed to that. Therefore, my prep skill has increased thanks to the scanner, and clinically, the quality of my crown impression taking has enhanced quite a lot. As you can see, it is formed like this. The distal part was a little bit difficult to scan. The yellow arrow indicates the distal of number 6 is not properly scanned, which is communicated to me immediately so that we don't miss that part. Thanks to this scanning, we have been able to get a very satisfactory prosthesis designing process. As I said before, when we get the bite, even the calculus of margin portion can be accurately captured. Thus, occlusion of the prosthesis doesn't need to be modified or adjusted to get very good prosthesis. The first and the utmost important portion is to get very precise scanning data. That is the first step, and I would like to emphasize that again. If you look at the margin of a natural tooth, you will see several of them, the color version, and you can compare them by changing colors. Actually, the margin should look like this. It should be as good as this so that we can have a very well-fitting prosthesis from the Modeless crown when it's delivered to the patient. In the past, we sent the model to a lab, and there adaptations were made. However, this is a Modeless process. Therefore, if the margin is wrong or not quite right, prosthesis would not be fitting very well in a patient. Therefore, precise margin data is very important. Let's look at Inlay and Onlay. In this case, this is much convenient or simple than crown. Clinically, using oral scanner, I believe this has been the best item that has been improved. When it comes to impression taking, Inlay Onlay has improved quite a lot using the scanner. This is a clinical picture of a patient. Number 37 had caries, so it is prepped and it is being scanned. This is hardly edited version of the image, and there are some missing unscanned area. When you are scanning, make sure that you don't have this missing unscanned area to have very good inlay or onlay. And one day Inlay Onlay is recommended to any clinic. You could do it very simply. This is the prosthesis design already done. It is delivered to a patient. When you adjust the setting values, you will be able to realize the prosthesis can be very precise using this way. Lastly, let's look at implant case. There's one benefit in implant scanning. In the past, we used to pick up impression, that was all. But before inserting the scan bodies, emergency profile is scanned first, and then insert the scan bodies to scan. Then The lab analog locations are registered digitally in the model. So impression taking with the scanner is very simple. We used to make holes in a tray for pickup, impression coping, rubber impression taking is done, and remove the screws. A lab analog is connected and stone is poured. It was more complicated process than a crown fabrication process. As you can see, compared to the natural tooth single crown impression scanning, this is much simpler. Impression taking for an implant with a scanner. So a protocol or process are available for us to make a very good implant prosthesis using a scanner. The process is very simple and convenient to use. Q&A session. Let's look at the questions. Which gives more precise prosthesis between oral scanner or impression taking? The Modeless process using an oral scanner and the conventional rubber impression taking. If you compare them, I cannot give you the only and definitive answer, but based on my clinical experience, the conclusion is the Modeless process with an oral scanner is far superior precision, far more convenient. It's incomparable to the rubber impression taking. There are some reasons on my part. First, the rubber impression taking or stone pouring has the expansion and shrinkage errors, and depending on who works on the rubber impression taking, depending on the staff, the precision level would be different. There is a seasonal variance as well as errors in the model pin work. The mounting on an articulator also makes a lot of errors, so many errors. So in the Modeless approach using oral scanner, there is only one type of error associated with the oral scanner. So in adopting the Modeless approach, I looked at the errors made in the two different approaches. Less errors were made when oral scanner is used for the fabrication of prosthesis. That's something I observed with my own eyes and hands, and I also felt it with my body. So Modeless process using oral scanner is much more precise in terms of the fabrication of the prosthesis. But one thing, for full mouth one-piece prosthesis, for example, from number 7 to number 7 on the other side, model needs to be used compared to the approach using the oral scanner that is more precise. The next question, in adopting the oral scanner in the clinic, what are the barriers? The intraoral scanner is adopted in a clinic. The most difficult part would be it takes a learning curve for people to get used to it. Dentists or staff, both of the professionals need to understand the new technology and apply it clinically. So some efforts need to be exerted by both parties to get used to it. Conventionally, the precise impression taking was possible through training. Now, new impression technique is adopted using the oral scanner. Therefore, the staff would resist to the adoption of new technology. So it may take some learning curve before they get used to it, and that may be the biggest barrier. The third question, what need to be considered when choosing an intraoral scanner? In choosing a scanner, I believe many dentists would know about that already. Before I talk about it, one of the roles of the scanner is to get acquire very precise data from a patient. Therefore, the precision of a scanner is the most important thing. Video type precise scanners were not available that much, but many companies upgraded the scanners and video type scanners are available, many of them. And the price range is quite broad, so fitting to your dental office, appropriate price and appropriate performance scanners can be chosen. In applying the scanner clinically, the tip size is important. If the scanner tip size is very large, it is difficult to scan in the posterior region or adjacent contact region between teeth. Therefore, it is better to have a scan tip size small. If scanner runs very slowly or it takes a lot of time for post-processing, if the speed is slow, it will be very hard for the dentist as well as the patient. So you'd better choose a scanner with better performance. Thank you. I am Dr. Chun Se-young. I'm with the Good Morning Dental Office.